Okay, so I'm Hernan Garaski, for those who don't know me. So this is our first neuromuscular mystery case rounds organized by the NMD4C. So we hope that you are as excited as we are. Want to introduce our two moderators that probably you all know. So we have Dr. Aaron Eisenberg and Christopher Schusmith here with us, and the two fellows that will have introduction in more details is Alberto Lehmann and Corey Basher. So I just want to give a few guidelines on how the neuromuscular mystery case rounds is going to be. So it's a mystery case, so please don't disclose the diagnosis if you actually know it or you think you know it, okay? We'll have actually a time for questions at the end of the case. There are going to be between 4 to 5 polls within the case, so you are welcome to actually to vote, and it will be interesting to analyze the responses on of you guys, and at the end, of course, if someone wants to actually talk, and actually you can actually raise your hand on the raise your hand, and we'll actually give you voice if you don't want to talk through the chat. Beside that, I'm just going to give some announcements. So in the future, please, these are the upcoming webinars and events that we're really excited to actually be part of it. This is actually especially for the fellows, which is the Early Career Forum. So for all the fellows that are really interested, please register to NMD4C and attend to this exciting forum. And then the genetics, the webinar series on genetics is going to be on March 2nd, and it's going to be about genetics neuropathy. So if you can attend, that will be like great. So for today's agenda, we have two cases. It's going to be like this in the future as well, one pediatric and one adult. The pediatric case is going to be presented by Dr. Alberto Lehmann, and the second one will be by Corey Basher. This is the learning objectives, although it's a presentation that the staff and the people who knows more can actually participate. We really encourage all the fellows to actually participate more actively. So please don't be shy and participate. So with that said, I'm going to give the word to Dr. Aaron Eisenberg so he can introduce Alberto Lehmann. I'm going to stop my to share my slides, and Alberto, you can present.
Okay, well, so everyone, welcome. Thank you all for joining us. Very happy to introduce Alberto Lehmann, who is an adult neurologist, but currently training in pediatric neuromuscular medicine at Sick Kids. He's originally from Argentina, where he went to medical school at University of Buenos Aires, and completed his residency at an institution that I'm not going to try to pronounce with my poor accent, but the short form is IMAC, I believe, in Argentina. Very happy to have him present the first case.
Thank you very much, Aaron, for the presentation. I'd like to thank all of you for participating in this neuromuscular mystery case round. And the case we want to share with you is a case that we think is very interesting because it has a lot of important learning points to discuss, and so we want to share this with you. I have no disclosure for these presentations, and the clinical case is a case of a 17-year-old female with term delivery who present with severe congenital hypotonia and muscle weakness with respiratory compromise at birth, with tracheostomy and G-tube dependence and recurrent aspirational pneumonia, and who went under scoliosis surgery when she was 14 years old. She has no consanguineous Portuguese parents and an older sister with the same phenotype who passed away at 5 weeks of age. These are the photos of the patients. At the left, you can see the patient wheelchair with severe contracture in the ischiotibialis, and she also present contractures in the Achilles. You can see mild atrophy in the both hands, and in the right photo, in the right side, the photo of her face, you can see bilateral ptosis with severe facial weakness and severe masticatory muscle involvements. This is the video of the patient where she is trying to follow the finger of the examiner. But as you can see, is almost a complete ophthalmoplegia of the patient. She has the bilateral ptosis. And in the tongue, you can see a normal trophism of the tongue and without fasciculations. Okay. Okay. Other important history of this patient, she has a global motor delay, she never walks, and the patient reports to be stable of her symptoms in the last months. She has a normal cognitive development, and now she's attending school virtually, but completely normal in the cognitive development. So the first question to you is, where do you think or localize this disorder? In the anterior horn, in the peripheral nerve, in the neuromuscular junction, or in muscle? I'm going to wait until we have the response. Okay, the 52% consider it was muscle and 40% in the neuromuscular junction. A lower percentage consider that it's probably an anterior horn or peripheral nerve localization. Okay, we'll continue and after we'll discuss that. So the first investigation we want to share is the CK level, that the last one in the last year was normal with 20 international units per liter. The motor nerve conduction shows reduction in the motor amplitude we recorded in the distal muscles with normal latency and velocities, and normal sensory nerve conduction studies. This is the repetitive nerve stimulation in the ulnar nerve and the spinal nerve. Okay, the results of the study, I'm not going to tell the results or the interpretation, but we can discuss later on in the discussion, in the final discussion of this case. Okay, this is the repetitive nerve stimulation. This is the voluntary recruitment of the patient. At rest, the patient didn't show any spontaneous activity. And this is the voluntary recruitment with minimal efforts. Well, now with these new investigations, what do you think are the most probable diagnoses? Congenital myasthenic syndrome, centronuclear myopathies, mitochondrial myopathies, or nemaline myopathies? Well, well, it's interesting the response. 24% consider congenital myasthenic syndrome, 24% as well, centronuclear myopathy, mitochondrial myopathy, 24%, and a 27% nemaline myopathy. So it's very similar, the clinical suspicion in this case. So regarding or in accordance with your probable diagnosis, what other or more investigation you will consider necessary? A muscle MRI, a nerve biopsy with electron microscopy evaluation, muscle biopsy, specific panel, or a whole exome sequencing? What do you think will be more helpful for the diagnosis? Well, muscle MRI, only 5%. No one choose nerve biopsy. A muscle biopsy is 38%. Specific panel, 38%. Or a whole exome sequencing, almost 20%. So in this case, because of the clinical features of the patient with severe congenital myopathy, with severe weakness at birth, with facial muscle involvement and ophthalmoplegia, the first probable diagnosis considered was Nemaline myopathy, and this genetic test was done in 2014, and it includes ACTA1, CF2, KLHL41, KBTBD13, KLHL40, Nebulin, Troponin, and Tropomyosin 2 and 3, and all were negative. So, and now how to continue with the investigation? Well, in this case, the patients underwent for a biopsy. I'm going to show you the slices of the biopsy, but I'm not going to comment the findings we are going to discuss later. This is the hematoxylin eosine stain. This is the Gomori trichome stain. And finally, this is the electron microscopy. Okay. So at this point, with these findings, here with the negative genetic panel, we have to discuss how to move forward with this evaluation and which are the probable differential diagnosis to consider. If we consider the clinical features of this patient, in a patient with periocular involvement, we must distinguish if the patient has or doesn't have ptosis and ophthalmoplegia. If a patient present with periocular involvement but has no ptosis or no ophthalmoplegia, we can consider some congenital myopathies, the desminopathies of facioscapulohumeral dystrophy. In patients who present with ptosis but not ophthalmoplegia, one can consider myotonic dystrophy, FHL1, tropomyosin 3, or pyroxy-D1. And in patients who present with ptosis and ophthalmoplegia, we can consider oculopharyngeal muscular dystrophy, some mitochondrial myopathies like the chronic progressive external oculoplegia, the congenital myasthenic syndrome, and the congenital myopathies like centronuclear myopathy, central core myopathies, some Nemaline myopathies, or CAGNA1S. Okay. The EMG, we know that this is with a 50 microvolts gain. You can see that they are very low amplitude, brief duration, and polyphasic, so it's very suggestive of a myopathic pattern. Remember that the nerve stimulation, repetitive stimulation, was normal in the ulnar and in the spinal nerve. And regarding the biopsy, we analyze the hematoxylin eosine stain. We can see some variability in the fiber size, with some fibers, round fibers, so very suggestive of myopathic features. Something very characteristic in this disorder is the increase in the connective tissue. And also you can see some internalized nuclei, but less than 25% to consider this a centronuclear myopathy. In the Gomori trichome, we can see some cytoplasmatic inclusions, but they were not present in the nuclei. And in the electron microscopy, we can see this inclusion that are the rods or Nemaline bodies. So the anatomopathological diagnosis was a Nemaline myopathy. And remember, nowadays, up to now, we know that exists 11 genes associated with these conditions. The most common are ACTA1, that is the autosomal dominant, the most common form, but it's also can present like an autosomal recessive. And the Nebulin, that is also an autosomal recessive disorder as most common. But if we consider this biopsy with Nemaline bodies and in a patient with ophthalmoplegia, it would reduce the differential diagnosis to two genes, the KLHL40 and the LMO3. If you remember, the first panel done in 2014 was negative for the first gene. It could be possible that it is due to a non-coding mutation, or it could be the second gene, the LMO3. So in these two genes have very common pathways in the physiopathology of the disorder. The KLH-L40 basically helps in the correct folding of the nebulin and LML3 and inhibits the degradation of these two proteins. And when you have a knockout in this gene, it produces misfolding in these two proteins and degradations of the nebulin and LML3. And the LML3 is a gene that encodes for a protein called lamodin 3, that is a protein that we can find in the thin filaments, in the endpoints of the filaments, close or very near to the M line. And it associates and it's expressed from the early stage of the muscle differentiations. Its form part is member of the family protein of tropomodulin protein family, and it's helped to the normal differentiation of the sarcomeric in the muscle and in the skeletal muscle. And when you have a knockout of this gene, it produces a disorganization of the sarcomeric, okay? This publication was done in 2014 and include a case series with some patient with the same phenotype that this patient that we present. With, if you see the photo of these two patients, you can see that they share the clinical feature with severe facial weakness, severe matricatory weakness, bilateral ptosis, and the same findings in the muscle biopsy. So this patient, we repeat a genetic test, a genetic panel for Nemaline myopathy for this patient, where it was found an homozygous deletions in the LMO3 genes that produce premature stop codon in this gene. So it was considered a pathogenic mutation and the cause of this myopathy. So the final diagnosis is an Nemaline myopathy associated to this mutation in the LMO3 gene. Well, I'd like to thank all the neuromuscular team at SickKids and all of you for participating in this neuromuscular mystery case round.
Thanks, Alberto, for that. It's really nice. So I want to open the discussion, and if people want to have questions about the case, are more welcome. First of all, I'm going to look at the chat, and there are some comments around it. Nicolas Christian was actually mentioning initially that there are a few genes that were actually included, and yes, I agree with that. I think that's a super important point. When we think about genetic testing, and always review when it's a negative diagnosis on the genetic panel, always consider that the gene that you may be looking at is not actually included, or maybe it hasn't been discovered or described yet. But the other second possibility is actually the non-coding mutations. So going to that direction, I just want to ask the people, because I mean, one of the questions was actually which test you will actually request. And it was actually a tie between muscle biopsies and a specific panel with 38% and 38% in each, and then Wes in the third position. So I would like to open the discussion in terms of what do you guys think in general about muscle biopsies and eventually genetic testing in the molecular era? Like what we should be doing?
There's one hand up, Hernan. Hisham has his hand up.
Yes, please, if you can authorize.
Perfect. And I did see, Wendy, your hand up too, so let me know if you'd like me to unmute as well. But we'll go ahead and start with Hisham.
Thank you very much for organizing this meeting and this very great talks. My thinking was, I think it's a very fair question to either approach it into this molecular era by the gene testing. But in this specific case, differentiating it from other possible causes, which could be congenital myasthenic syndromes or something like that. But in this case, I think the biopsy nailed the truth that this is a myopathic disorder, and not but that, but actually underlined the genetic component in it, which made us revise our initial revision of genetics. And I think in this era, this is where we should be careful in approaching our tailored diagnostic approach. That would be my 2 cents here, I think.
So just to summarize, so you think that the muscle biopsy is something that we actually should prioritize. So in your own practice, do you think that you actually do muscle biopsy before actually going for genetic testing? Like just, what do you do your usual, like every day?
So no, if there is we don't go for a muscle biopsy if there is a clear genetic panel that we can go for right away, or there are specific genes, let's say a very specific, very typical DM1 or DM2 presentation of SHT. We'd be having a more targeted sequence based on the institution that I work in. But in this case, and the muscle biopsies, we would go for to differentiate or subtype the different inflammatory myopathies, or to make sure that this is a primarily myopathic disease, in order when EMG does not really differentiate the case. Does that answer your question?
Yeah, thank you so much. Jim, I think you have your hand raised.
Yes, just to mention that there's good data that has come out from several groups. I think probably the most compelling of which is from Kathy North's group in Sydney and Melbourne, showing that either gene panels or exome sequencing is both cost and time effective as compared to a biopsy first approach for essentially, when the primary indication is a muscle disease. And just to also reflect that there's different layers of panels that can be used. So, it depends a bit on your diagnostic certainty as to the subentity, but there's certainly neuromuscular panels that would be inclusive of all of the congenital muscle disease genes. And so if one isn't able to distinguish between a myasthenic syndrome and a myopathy, for example, one can do the gene panels. The question of panels versus exomes is both a intellectual question, but also a provincial approval and funding question. When there is an adequate panel, quite often the province will not fund an exome. And truth be told, the comprehensive neuromuscular panel at most of the commercial companies, such as Invitae or GeneDx, covers all of our known neuromuscular disease genes, so should be adequate. Obviously, this case kind of fell in that intermediate period before LMOD3 got added to the gene panel. So this patient had testing prior to that. And the other kind of interesting thing about this case is that it was one of the original ones from the publication, but the research sequencing never got communicated to the referring clinician or family. And so it wasn't until 8+ years later that we discovered that it was actually the same patient.
So in terms of that, Jim, I think it's really interesting. Actually, the pathogenic, it was reported as pathogenic because this variant was reported before. However, it's the same patient. So I know it's pathogenic, but this repeat individual, because it's confusing. I think they based their pathogenicity on a previous report patient. However, it was the same patient. What do you think about that? It's that clear what I'm asking?
Yeah, it's a really interesting point, and I think something to always keep in mind that there can be double counting of variants that can occur. And you can also see this where the same individual may be included across multiple publications, and then it gets counted as that variant occurring 3 different times, when in effect, it's just been found once. I think there's little reason to doubt the pathogenicity in this case for 2 reasons. One is I believe there was Western blot data. I'm not sure if this person's biopsy was included in that to support that the variants were affecting the LMOD3 protein levels. And the other is the phenotype is really quite striking for LMOD3. The KLHL 40 patients really never survived beyond the first year of life. So this presence of Nemelin myopathy with ophthalmoplegia really is suggestive of LMOD3 in the older individuals.
Thanks, James. Wendy, I know you posted a question, but you have your hand raised as well. So if you want to just talk, you're more than welcome.
Hi, yeah, thanks. I lost the feed for a sec, so I wasn't sure if you called on me earlier. So the slide that showed the algorithm for deciding on possible pathogenesis seemed to imply that if there's ophthalmoplegia, that rules out myotonic dystrophy type 1, which is in fact not true. Could you just verify that that slide is, because certainly in adults ophthalmoplegia is seen. Now, I'm not sure, not being pediatric neurologist, if congenital myotonic dystrophy can have ophthalmoplegia, but I would doubt that that would be exclusive and that the algorithm that was demonstrated, because I just went by quickly on one of the slides.
So how, yeah, I saw the slide. So my question is, how frequent do you see for the people in general, ophthalmoparesis in myotonic dystrophy?
It's more common ptosis than ophthalmoplegia.
I mean, ptosis, yes, but ophthalmoparesis, like how frequent do you guys see it? Do you see that's a typical feature? If you see ophthalmoplegia, do you think it could be myotonic dystrophy? Rare, have seen it once. Okay, so Shannon, thanks for that, Shannon.
So it's like a lot of things.
So Jim saying that never seen ophthalmoparesis in DM1. It's true, I never seen in DM1 to tell the truth. But if it's a feature that it's something that I'm learning here, like thank you so much for that, Wendy. Really appreciate it.
It's well reported.
Okay.
Thank you. We'll change the slide then, for sure.
Okay.
Nicholas Christian was asking, will you mind to remind us the specific features we can find in the muscle biopsy for LMO3 related to myopathy? I will assume he's actually discussing the specific forms of the rods. Alberto, do you want to?
Yeah, the rods is described that can present in pairs, like two rods, and like with the thin filaments in the middle, like a bar for exercise. But I didn't really appreciate that in this. I have no background in pathology to say I didn't see, but really I didn't see in this case at least. But it's described in the electron microscopy that you can see the rods in pairs and separate by the thin filaments between the two rods.
Yeah, I mean, these barbell rods, Nicholas, that they were reporting. We actually look into this case and we didn't see anything. It's true, for example, the KLH40, they can look like ragged red fibers when you just look it with the Gomori, because they are really small, really small rods. And that's something actually we were discussing with Jim. And when we see that, we tend to say, okay, maybe this is this or this as a differential diagnosis. So it's 5:30 already. I don't know if someone else have any other questions for Alberto or something that someone wants to discuss about this case. Okay. If we're good, then Christine, is all yours then.
Sure, we'll now move on to the adult case. So Dr. Corey Batcher is going to present his case. Dr. Batcher is an adult neuromuscular fellow at University of Toronto. And he was a resident at the University of Toronto preceding that and did medical school at the University of Saskatchewan. And so we're very interested to hear about his case.
Thanks so much for the introduction. Today I'm presenting, I don't know if anybody gets this reference from my slide, but it's a transformer reference. A little bit of nerding out, but that's what it is. Yeah, so my case presentation, let's see if it gets going. There we go. I have no personal, obviously, conflicts of interest related to the case, and the patient was consented for both publication of this case and the imaging as well. So I will skip over this because we already spoke about the objectives previously, but we'll just dive right in. So my patient is a 62-year-old patient who came in, he's a retired businessman who's right-handed. He has 2 children, both of which are healthy and really no adverse social history. He has a past medical history of rosacea on doxycycline and no other previous medical issues and no family history of any neuromuscular disorders. So he was referred to us from a sports medicine physician. He's a very avid cycler, and he presented initially because he developed significant quad weakness, which was limiting his ability to perform while he was cycling. And he actually presented for consideration of platelet-rich plasma injection into the quad itself. You can see the left quad is a little bit more atrophic as compared to the right side. And there's no involvement of the thighs at all. I mean, of the hamstrings at all. So he was referred for query weakness in the left leg. And the consideration at the time was a potential lumbar radiculopathy. So when he went through his history, he described a 6-year history of frequent muscle pulls in the left calf, which were triggered by exercise. It wasn't true cramping. He just described kind of a tightening sensation in the calf, but there was no contraction of the muscle or posturing of the foot at all. And about 1 year ago, he began to notice that he would get discomfort more proximally in the left leg, specifically in the quadriceps muscle. And again, the discomfort was triggered by exercise and would last about like several minutes to an hour after the pain started. And then he began to notice that he had difficulty pushing on the pedal, and specifically described difficulty with plantar flexion while he was biking. There were no sensory symptoms. He never developed any bulbar symptoms or history of diplopia or ptosis. No history of involvement of the upper extremities. He had no cramping, fasciculations, difficulty with gripping objects for myotonia, episodes of myoglobinuria, and he met all his developmental milestones. No back pain or radicular symptoms, despite his history of this possible left L5 radiculopathy, which I'll get to in a second. And then he had a history of chronic left shoulder pain, for which he had several investigations, and no history of preceding infection like polio or anything like that. When he had his MRI of the lumbar spine, which is from 2014, he demonstrated multi-level degenerative disc disease with mild to moderate narrowing and impingement of the left L5 nerve root. And that was the suspected cause of his presentation. And then he also had an X-ray of his left shoulder, which showed mild degenerative changes of the joint with normal anatomical alignment, and then ultrasound, which showed biceps synovitis. So when we examined him, I just highlighted in red the abnormality. The eye movements were normal. There was no ptosis. He previously was able to whistle, but when we examined him, he was no longer able to whistle. He actually didn't recognize he was not able to whistle, and he had difficulty making a complete seal of his mouth when puffing his cheeks. Otherwise, his phonation was normal. Really, no issues with tongue, no tongue fasciculations or anything like that. I now show you the proximal and distal part of his leg, and you can see that he has atrophy of the left quadriceps, but also a significant left calf atrophy as well. There was atrophy of the pectoralis muscles, and that was actually probably one of the most striking findings, was the degree of pectoralis weakness. And you can see here, it almost looks like there may be a little bit of deltoid weakness in the right arm. Deltoid atrophy in the right arm. But interestingly enough, despite this prominent shoulder girdle weakness, there was no scapular winging when we examined him. I summarized the motor exam in this table so you can see what was specifically weak. I'll just highlight it. Specifically, his external rotation was symmetrically weak, 4+, as well as his deltoids. But the remainder of the muscles more distally were strong. In the lower extremity, it was mostly hip flexion, like iliopsoas weakness, that was 4+. Otherwise, he had some distal ankle plantar flexion weakness that was 4+. And he was unable to perform toe raises on one foot on the left side. The strength was otherwise normal, and it was interesting considering how much this mild weakness impaired his ability to function when he rode his bike. With regards to his reflexes, his left ankle jerk was was down slightly, was the only abnormal reflex, and his plantar response to flexor. And just to quickly summarize this, his sensory coordination and gait examination were completely normal. So I won't bother reading this out to you. So this starts the first question of my case. And based on this clinical presentation of pretty much left quads atrophy and some left calf weakness, what do you think is the most likely localization? The brain, the spinal cord, the anterior horn cell, the nerve root, the brachial plexus, peripheral nerve, the neuromuscular junction, or the muscle? it looks like we got a good, okay, we got a good spattering, but most people wanted muscle, 77% of people, but there's also a significant people said neuromuscular junction and peripheral nerve, and some people thought it was central. All right, so, oops, sorry. All right, so I'll give you more information now. So we did his nerve conduction testing, and you'll see just that his peroneal motor response recording from the EDB was normal. His tibial motor response recording from the abductor hallucis was also normal. Sorry, the tables appear different because they're combined in our labs, so I have to separate them. And then the sural sensory response was normal. And then, as suggested by majority of the audience, he had reduced recruitment with small motor units in the left pectoralis major, but also very small polyphasic motor units in the remainder of the muscles tested, with some increased insertional activity in the left tibialis anterior, medial gastrocs, and vastus medialis, which suggests, based on that, I know this is a simple question for most people, but just in case there's fellows or residents or anybody else online. All right, most people are now in agreement that it's most likely a muscle disorder, which is great. So based on that, I don't know how the poll came out for this, but based on that, what would most people feel like they should order next? I can't actually see the chat, so.
I can, Corey, I can follow the chat. Nobody's
Sure.
entered anything yet. I don't see any hands yet either.
Okay, I can keep going if there's.
No, there's a couple, because people are suggesting diagnosis, so we're going to hold a diagnosis. So Dr. Dowling has said CK, see what CK is. Someone has suggested muscle biopsy. Someone has suggested genetic panel. So do you want to talk about maybe the CK and muscle biopsy and genetic panel?
Sure. So I'm actually going to not jump into that right now because I want to kind of hold back on what the possible diagnosis is. I just want to quickly go through the differential, and then we'll discuss the possible, or the way we investigate this patient in a second. So based on the pattern of weakness, as you can see, I kind of just highlighted it in this picture. You have a lot of asymmetric weakness in the left lower extremity, which is predominantly in the quads and pectoralis muscles, but also some facial weakness. So I think one of the ways we approached looking at this was trying to isolate what are the major causes of each of those in a focal manner, and seeing if any of them kind of overlap if you look at them all in totality. So first, with regards to quadricep weakness, some causes of focal quadriceps weakness is Becker muscular dystrophy in the adults. There's also the limb girdle muscular dystrophy. Interestingly, dysferlin and anoctamin 5, which are known to cause Myoshi-like or Myoshi myopathy and causing calf weakness, can cause more proximal weakness in the quads as well. The inclusion body myositis and hereditary inclusion body myositis can cause this as well. There can be a focal myositis and a polymyositis. Then there's facial weakness. Obviously, FSHD is one of the top that comes to our mind in the adult world, and I put an asterisk because it typically presents with an asymmetric presentation. Congenital myopathies, myotonic dystrophies, inclusion myositis again can be asymmetric, and oculopharyngeal muscular dystrophy. And then with regards to gastrocnemius weakness, as I mentioned, Myoshi myopathy and limb girdle muscular dystrophy, which are typically dysferlin, or not typically, but they can be dysferlin or anoctamin 5. And then there's hereditary IBM and FSHD. So if you overlap all those three kind of patterns, you kind of end up with three things in the differential, which is FSHD, IBM or limb-girdle muscular dystrophy. And so I think the question about whether a CK is very helpful in guiding what you'll do next, because in the Myoshi or Anoctamin or Dispersed limb-girdle muscular dystrophies, you expect to have a very high CK. In FSHD, you don't necessarily have to have a high CK, similar with IBM. And so the CK in this patient ended up being 411, which then pushed us to doing genetic testing rather than muscle biopsy. And the genetic testing we specifically chose because of the asymmetric presentation was FSHD genetics. And you can see that there is a deletion in the DUX4 gene with the 4QA haplotype in cis, which makes it a pathogenic abnormality for FSHD type 1. And so the question then becomes, I guess, what's atypical about this case? And the fact that he had so much prominent quad atrophy, it's not typically in the list of a common cause of quad atrophy. There was a study of 122 symptomatic subjects in the United States. And what they found was, in the top, I kind of put a box around the facial sparing cases. There have been a few documented cases of facial sparing, but those are all typically presenting with scapulohumeral weakness. But they actually documented 8 cases of proximal lower extremity weakness that was predominantly involving the iliopsoas muscles. Interestingly, it was always bilateral, and it was always associated with scapulohumeral weakness. So what makes this case, our case, unique is that there's never really been documented to have a unilateral case of quads involvement. So that's interesting. There have been another study which looked at more focal presentations. And this was a study came out of the Mayo Group more recently. And I highlighted the top set of 5 patients. These top 5 patients had focal limb atrophy, so they didn't have any scapuloperoneal weakness, or so they said. However, when you read through their actual study, they do document a few patients that, I think it was patient 1 and 2, who did have a bit of facial weakness when they re-examined them. The last 2 patients were patients that presented with axial weakness. And interestingly, their patients who presented with axial weakness presented later on in life were typically female. And at that point, I guess another consideration when it comes to axial weakness or hyperlordosis in those patients is some sort of central neurodegenerative process or motor neuron disease that should be also considered as possible etiologies. When it came to patient 6, that was an interesting patient because they felt that patient presented with dyspnea at onset. There was nothing else other than shortness of breath, which is something that is not typical for FSHD and usually makes you think of alternative diagnoses like Pompe, for example. And so that was a unique patient in that population. And then finally are the top 2 patients who presented predominantly with with shoulder weakness, and it was focal. But again, those patients had a family history of siblings with FSHD. And so they, even though it was focal and it could be attributed to other causes, they felt it was most consistent with FSHD. So what is the pathophysiology of FSHD? It's a bit complicated, but obviously the major problem is a toxic gain of function of the DUX4 gene, which typically results in the inhibition of the MyoD gene, and MyoD encodes the transcription master switch for muscle differentiation. So by inhibiting that, the muscle can no longer differentiate. It also inhibits the expression of genes involved in the response of oxidative stress, which results in obviously oxidative stress for the muscle and increased risk of muscle death. And finally, one of its direct targets is the PITX1, which is a target gene for TP53, which has a major role in DNA repair, cell cycling, apoptosis, and obviously has implications for muscle atrophy. So that's the proposed pathophysiology. The confusing part comes to the mechanisms of actually resulting in the toxic gain of function of DUX4. So normally you have two scenarios. You have on the left side patients with a normal DUX4 repeat, and then you have the 4QA haplotype or 4QB haplotype, and you need the 4QA haplotype in order to produce DUX4. On the right side, I just wanted to highlight the methylation that is typically there, and the methylation around the DUX4 gene around the D4Z4 gene typically prevents expression of DUX4. And so when you get FSHD type 1, you get a deletion, and that brings the poly-A tail closer to the D4Z4 region and results in expression of DUX4. And then that's 95% of the cases. And then you can get FSHD type 2, which results in not necessarily from the actual deletion, but hypomethylation of the gene, which results in transcription of the gene. And that is FSHD type 2. So in our case, just to review, our patient had the deletion with the 4q8 haplotype and subsequently has a diagnosis of FSHD type 1. So I think there's some key points I just wanted to review quickly before I wrap up. So classically, scapulohumeral weakness is attributed to FSHD. However, in rare instances, I think it's important to keep in mind that it can be proximal, and it can also involve the posterior leg, and it can also be focal, which is unusual for a disease that's supposed to be obviously with more muscle involvement. It requires dedicated genetic testing, and I think that's important because we often do a panel approach. And if you right now, FSHD, at least in Toronto, is not included in the panel, and therefore, if you do a panel, you'll miss that diagnosis. And another thing is important to note is that the deletion in D4Z4 gene, there's an inverse relationship between the actual repeat length and the severity of symptoms. And then finally, you can have patients with hypomethylation and FSHD type 1, which results in a more severe phenotype. So something to consider if your patient's not fitting that FSHD1 phenotype is to look for the hypomethylation genes. And that's it.
Thank you so much, Corey. So I will just leave this open now for questions. So Wendy has a question. So Wendy, if you want to unmute yourself.
Yes. Hello.
Hi.
The respiratory presentation or respiratory involvement, did the paper indicate if the patient had scoliosis? Because in my experience, the only time there's been respiratory involvement is when there's significant kyphoscoliosis, and it's restrictive on the basis of the musculoskeletal rather than the muscle itself.
Yeah, interestingly, the paper didn't go into that very much. Although when you actually read the description of the patient, they talk about them having axial weakness, but never described what the axial weakness is. So it's a good point. I'm not sure if the patient had. They didn't mention about any spinal abnormalities or scoliosis or kyphosis, so I wouldn't be able to tell you that information. But the patient did present primarily with just dyspnea to them.
Thanks, Wendy. In the chats, I think a lot of people had wondered about the diagnosis, I think, because of the peri-oral weakness is probably what the key was, because a lot of people are getting that. I don't think there's any questions in the chat. Anyone else have any questions? So please raise your hand if you've got a question or add a question to the chat.
I have a question. Can I?
Yes, hi.
And maybe this is for the pediatric people here. How it was mentioned FSHD2. How frequent do you see, if you actually have seen any cases of facioscapulohumeral dystrophy type 2 in pediatric population? I don't know if someone wants to have any expertise, or maybe nobody actually have seen it. Personally, I have never seen it. So no. Then
I think even amongst adults, I could say I've only seen it a couple of times myself, and out of FSHD is one of the more common muscular dystrophies we see in the adult population, like just in a regular neuromuscular practice. But FSHD2 has been pretty rare.
So Shannon,
yeah, sorry.
Oh, so Shannon said that she saw a 17-year-old, but it was a brother of a patient who was diagnosed initially. So she's put that into the chat. Jim has said that it's not reported. He's written that down too. And yes, most people have never seen it. I just draw attention to what Shannon has also put in the chat, where she's talking about the ventilation point that Wendy had up earlier, which is that ineffective nighttime ventilation may be seen in FSHD with intercostal and abdominal weakness with a protuberant belly. Okay, so we also now have 2 extra hands up. So I'm going to, Wendy, I'm going to do you second, just I'll get Hisham first and then I'll go back to Wendy. So Hisham.
Thank you very much. I was just wanting to ask about the frequency of seeing FSHD. Do you think, and this is for more people of expertise, could it be for the difficulty in diagnosing the mechanism of diagnosing FSHD type 2? I know the methodology of it is different, so it's a little bit more advanced than 1. And it has more difficulty in interpretation of the results themselves. So could that be, how would one approach that if the clinical suspicion is high?
So you're talking about the methylation differences, Hisham? Is that what you're asking
Yeah.
about?
Yes.
I am going to, Shannon, just because you have most experience from my perspective on this. Shannon, do you want to unmute yourself and maybe offer your opinion? Or Wendy, if you have any opinions on this, I'm going to offer you 2 up. Shannon's going to unmute yourself. Shannon.
Hi. I mean, I'm a pretty practical, pragmatic person. I start with FSHD1 testing, which in Ontario is widely available through CHIO. Often FSHD2 is phenotypically similar to FSHD1, and so I would then go on to test for, I can't even, SMCHD2, usually in a panel, because we don't have it, I don't believe, widely available in Ontario as yet. And with respect to the methylation status, I haven't looked at that since the gene was identified by the consortium many years ago. Before that, I would send samples to the Dutch group, Van der Marle's group, for methylation, but I haven't done that in probably a decade. So I'm not sure if that related to the question or not.
It does relate. Thank you very much for the clarification.
Thank you both for the question and for the assistance, Shannon. Wendy, you have a question as well.
It looks like you're still muted.
Thank you. Can you actually see me? Okay. So I didn't have anything to offer from the last issue. And Cecile Fan is now our muscle expert, and I sort of bowed out of that. I'm certainly, with the explosion in genetics and testing in the phenotype, genotype, disassociation, I've become just sort of muddled. But I have a pile on my desk of negative FSHD reports from when Calgary was doing them that I have to resubmit for testing to CHIO, because that's the pathway that Alberta is now following, is to send them to CHIO, where I believe we get FSH1 and 2. And I have got a bunch that are very typical and await further testing. So the question I had was, in the presentation, I don't have any experience with the LGMD subtypes that you were talking about, but asymmetry always makes me think of FSHD, because it's one of the common muscular dystrophies that can have very asymmetrical presentations. And so I wondered how others felt about that, that approach, that it's very asymmetrical in many patients.
It's Shannon here. I think I was unmuted. I think, and Aaron O'Farrell may want to comment as well, but the asymmetry is key. And I look for it even in very subtle asymmetry in the ability to bury eyelashes and in the symmetry of the lip pucker. Sometimes that can help you. And in this fellow, things that you noticed, although he had no scapular winging and his clavicles were normally seated and horizontal, he had that marked pec wasting with the axillary crease. And so seeing that, I probably, just in the order of pretest likelihood, would have started with FSHD testing.
Thank you. That sort of reinforces my simplistic approach.
I was going to say, Wendy, just if I'm still unmuted, one of the things about CHIO is you can't have your sample arrive on the weekend or it sits on their loading dock and is no good on a Monday.
Oh, no, I totally know that. So I have a patient in Grand Prairie that we're trying to figure out the logistics between Northern Alberta and CHIO. It's a bit of a nightmare.
Well, I'm muting now. So Erin, do you want to add anything? Because I saw you had your hand up.
Yeah, I agree with Shannon's comments. I would say that we, in Quebec, we usually send to the Iowa lab, and they do a very good FSHD 1 and 2 assay. So they have a reflexive algorithm where if the FSHD 1 doesn't, so they don't find the permissive haplotype of the D4Z4 repeats, they'll go right ahead and do a methylation assay and look at FSHD 2. And they've actually picked up FSHD2 cases that have been missed on panels, because FSHD2, it can be found as part of a point mutation in a gene. You don't need the methylation or a deletion assay, but it has been missed on larger panels that we've done. So I find the Iowa lab is really helpful. I would say also that for me, FSHD is a great mimicker. I've seen all kinds of strange phenotypes that turned out to be FSHD rather surprisingly. So I think I tell my residents and fellows, if you don't know what the diagnosis is, think about FSHD, even if the phenotype is atypical.
Great, thank you so much. So it's 2 minutes now to 6. I think since we don't have anything else in the question, I think Hernan probably wants to say something. But I would like to personally thank both our 2 fellows for presenting. You did a fabulous job. We would like to continue these mystery rounds approximately every 3 months, so 4 times a year. And since Toronto offered this one up, I am going to offer my fellows up in London for the next rounds. So we're going to do a London-based rounds next year. And I saw Mona on, so Mona, take note. And I think my 2 fellows are on from the adult side. So we'll do something similar. And there's a strong act to follow. So both of you guys did a very, very good job today. So thank you so much. Hernan, I think you might want to say a couple words, so I'll pass the mic on to you.
So thanks, Christine. Thanks everybody to actually join to the first mystery case rounds. I think it went great, and we are going to improve from here now. So we are waiting for your response and your feedback. If you have any ideas on how to actually improve it, we encourage you actually to provide us that. So and everybody, thank you so much. And I hope I see you soon, like in three months, and we'll coordinate which, we'll try to get the schedule for the whole year. If your fellows think that they want to participate presenting your centers, please just email me or Erin, and we'll, or Aaron or Christine, and we'll be glad to actually schedule on the talks. Thank you, everybody, and see you.
Bye. See you.
Hernan, did you want us to stay on the call for a few minutes?
Yeah, if you can just stay, just to wrap up.
Perfect.
So there's still 3 attendees. Can you, Omira, can you, I don't know if for Anu, Ario, or Sulaiman, I don't know if you can take them out. Sorry, guys.
All
Done?
set.
Okay, great. Thank you, guys. I think it went great. I don't know your thoughts. I mean, this is something we can discuss later on. I think it went good. I mean, the time was good. I mean, everything was okay. I think one thing we need to work on is more like the interactivity. One thing I was thinking is at the end, it's trying to, before actually giving the diagnosis, maybe we can open to discussion on what the people think. So there's more interaction and more like, okay, this is more like mystery case, like everybody have thinking and thoughts about it, and then we just disclose it. That's something to consider. I don't know what you guys think.
I think that's fine. It's tough from a time perspective to manage everything. That's the only thing. I liked it, and I like the fact that it was done at it could be at a basic level, or it could definitely be at the fellow level. I think we somehow have to reinforce it. Please don't give away the diagnosis in the chat right away, just so people start thinking about it, because it happened in both cases that happened. But yeah, because I think it's helpful if people withhold that information, so people just don't get pigeonholed into a diagnosis when they're thinking about it.
Yeah, we'll try to do that. Yeah,
I think the format was great. I think that anytime you bring in genetics, there's layers of expertise, and I really like that. Like, you know, there was great participation from fellows up to, you know, people with really nuanced genetic knowledge, like Jim Dowling. So I think it was perfect. I think the timing worked out perfectly. So I think the formatting really works. I think that was great.
Okay. Thank you, Alberto and Corey. I think it was fantastic.
It was fantastic. Fantastic.
Yeah. And it was great cases to begin with, so that was really, really good.
Yeah.
So, Christine, I guess you'll present the next one. We need to find a second one.
Craig, I'm sure Craig, I'll get Craig to get one of his, so Mona, I think, is the one who's got his main fellow right now, so I get her to.
If London can actually present, we can actually do it something like that. We can go like center by center.
Yeah.
And then also, Craig, if he's going to present, that would be like fantastic. And then it would be nice to actually provide the whole schedule for the whole year. I know that we have other people that wanted to participate, so we'll meet later on to discuss it.
Okay.
Thank you, guys. It was great. I'll see you next time, and Aaron, I'll see you in 2 minutes for something else.
Okay, thanks, guys.
Bye.
Bye. See you.